So here we are, we're about 3.5 months out from the implementation of the Affordable Care Act, and there are lots of things going on, states busily setting up exchanges and so forth. And so I'm curious to hear your take on what you see unfolding over the next several months as the Affordable Care Act sort of takes off in January, and how things are going to look different, let's say 6, 9, 12 months from now.
Well, I think that in some respect, the day for go is October 1, when the health insurance exchanges or the health insurance marketplace goes live, and people can start to shop for insurance under the new health insurance marketplace. That'll be, I think, a time where there'll be a lot of reporting on what's going on, and a lot of people trying to prognosticate about what's going to happen over the next year just based on startups. So I think we should probably hold off on making firm judgments right on October 1. But I guess what I see unfolding is the people who are waiting for October 1 are people who have been waiting for health insurance because they need it really bad. And so those are the first people in line. But on the other side, I think the insurers and also know that the sickest are the first in line, and the sickest in health insurance are often the most expensive. So the key to making the health insurance marketplace get off to a good start is outreach to get everybody in line to start shopping for insurance. How well that works is something I'm looking forward to seeing. I expect there to be great variation across the country between different states and in different parts of the country, depending on how well states have prepared for this and how much states have embraced healthcare reform. I think that, I'm quite excited to watch this happen as someone who, kind of lives and breathes this stuff. It's kind of when you want to be playing in this field. So I guess that's the main thing I would say we're going to have to watch out for and see in terms of how implementation is really getting off to a good start or not.
So when I asked you about the Affordable Care Act, you sort of telescoped in on the exchanges. Zeke, do you think that is, when you think about the Affordable Care Act 6, 9, 12 months out, is the first thing that you think about the exchanges and how they're going to be doing and so forth?
Well, be it for me to correct you, Mark, but let's be clear. The Affordable Care Act was passed March 23rd, 2010, and lots of it's been implemented already. It's not like implementation day is January 1st, right? We've already had, I would suspect many people in this audience have benefited from having their children on their health plan. I know that one of my daughters has made use of that. And we've had a lot of other parts to the Affordable Care Act already implemented. So I do think we need to be clear. This is going to be the part related to expansion of coverage. That's the biggest, but it's by far, I counted up the pages. It's only 222 pages of a 900-page bill.
So 3/4 of it we're done with?
Well, no. My point is that that's only a part of it. There's a lot of other stuff in the bill, some of which has been implemented, some of which will be implemented. The last thing to be implemented will be in 2018, the Cadillac tax. But to go back to your point about the exchanges, this is a pretty pivotal time. And I'd just like to tell us two stories that I think illustrate the importance of what we're about to encounter. I don't know, what does my hair say? About 6 weeks ago, I was in the barber's chair in Philadelphia. And I got to talking with the barber. You know how they try to keep you happy, so you'll give them a big tip. And he found out what I did and the fact that I worked on health care. And I asked him, so, do you have health insurance? And he tells me no. I said, well, does a salon not give you insurance? He says, no benefits. And I asked him, and he says, well, I've been basically without health insurance for 10 years. And I said, well, what do you do when you get sick? Well, he says, I really try to avoid going to the doctor. One time in the last 10 years, he has been to the doctor. He fell down and smashed his elbow. He was thought it was just a bruise, trying to avoid it. After about a week, he knew it was broken, went to the emergency room. They put him in a cast. He then went to an orthopedist, which they recommended. They took the cast off. but he hasn't been. So I said, well, do you know about the exchanges? No idea. I said, well, you know, if you could get insurance, would you want to get insurance? Absolutely. So he asked me, how much do you think it's going to be? I said, look, I don't know how much you make, but there's going to be subsidies for people like you. And he says, well, you can see the wheels turning in his head. He says, you know, do you think it'll be about $150 a month? I think I can do $150 a month. And I, you know, reiterated, I have no idea, you know, what your income is, what the rates are going to be in Pennsylvania. They haven't been released. But I think 150 is not an unreasonable amount, given actually about a week before that, California had released its rates, and you could get insurance as low as $34 a month in California with subsidies. And he looked and he says, thank God for everyone who worked on Obamacare. And that's just one example. I'm going to check in with him because I need another haircut, as you can tell. And after October 1st, we're going to go shopping together on the exchange to make sure he gets health insurance and see what it costs. But he's not unique. That he didn't know, probably half the people who are going to be eligible for the exchange don't know that they're eligible. I would say that the communication strategy leaves a little something to be desired, although it's obviously ramping up. But I could tell you stories of people who do know. There's a guy who I interviewed, a gardener from Los Angeles, who's 30 years old, runs a small business. He has about 4 employees in addition to his brothers. They all make about $17,000 a year, working 6 days a week, 8 hours a day. And he told me, you know, he's tried to get them insurance. It's $500 a person a month. He certainly can't afford that. And he told me, you know, he's calculated out if it's $200 a month for these guys who are between, you know, 22 and 34, he'll be able to afford that, and he's going to get all of his people insurance. And so I'm expecting actually a bigger surge than the CBO projections. The CBO, the Congressional Budget Office, projects 7 million people will sign up in the first year for exchanges. If you talk to people at the state exchanges, California, Maryland, and others, they're actually anticipating more people will sign up. So that's the first thing. You want a scorecard of what to expect. Number one, on March 31st, when the enrollment ends, are we going to have 7 million people less or 7 million plus? If we have 7 million plus, we've had much better than projections, and I think we'd have to conclude that this is a big success. Along the way, I think there are going to be a lot of bumps in the road. Computers aren't going to work somewhere. The interface isn't going to be perfect. Maybe the connection with the IRS will be a little bumpy. Those are technical glitches. The computer guys will take care of that. I believe even within the 6 months, the system's going to work better. And I'm sure that by next year, when we do this again for the 2015 season, you're going to have systems that work better, web pages that look better. It won't quite, I think, be at the Amazon shopping experience, but it'll be getting close. And I'm sure by 2016, it will be equivalent to the Amazon shopping experience. And I think most people who shop will be happy. My biggest fear, actually, is it'll be too successful. I don't think most places have planned for a surge of people. And if you have a surge, I think a large part of this could fall apart. That actually could be the sort of bad irony, that a lot of people want it and the system isn't quite there to handle it. But I actually predict that we're going to be, first thing you can hold me to, you can call me up on April 1st and, you know, more than 7 million people. But if I'm right, I hope you take me out to dinner. So,
so I want to follow up on this point that you raised about Amazon. So one of the challenges for these exchanges, and I'm going to put this question to Dan initially, is that a lot of the people who are potentially signing up for health insurance through these exchanges may not have had coverage for quite a long time. And they may not have recently been thinking about sort of, how do I choose a doctor? How do I choose a plan? How do I know what hospitals I want to be in, and so forth? And so I think for these exchanges, figuring out how to provide this kind of information might be challenging. So Dan, what do you think? If you're sort of the person implementing these exchanges. And you talked about Amazon. Amazon, you can go on, purchase a book, purchase I recently went to Amazon 2 days before my anniversary and thought, oh my gosh, it's 2 days away. Very quick, and it was, and I didn't get in trouble, and I was very thankful to Amazon, and all went well. Dan, so when a person comes to this exchange, what are they going to see, and how did you sort of give the person enough information to make the right choices, but not overwhelm them with so much information that they're kind of paralyzed? Because one thing is just getting this whole bill on the radar screen of people. Another is to get them to actually the point where they say yes, purchase. And will they make good purchase decisions?
So some of it's going to depend on, if an individual is interested in purchasing insurance and they are not well versed in, they haven't used insurance in 10 years, they don't really understand the differences between a deductible and a co-insurance and copay. In some respect, it doesn't matter how pretty the screen is. They're going to have trouble navigating it. So if we take that person as an example, I guess for me the Amazon experience is, okay, I got to go shopping for clothes and I don't know what to pick, and I just get my wife to say, what should I buy? And she's the expert, and I don't have to be the expert on what color tie to get, or which type of shirt to buy, and so.
But it's a new suit he's wearing tonight.
It's a new shirt, someone else navigated it for me.
Brand new.
I showed up, they put it on me, and I took it. So I think that's another kind of navigator experience, is that a lot of the states are setting up an infrastructure to essentially have people that can walk you through the choice and educate and explain along the way. And hopefully that's a minority of the people that would go onto the exchanges, and that they're going to be also, it's going to vary a lot by state, but for Massachusetts, which has had an exchange in place for 5 or 6 years, you can go on, and they've had to figure this out over time, but I have my students go on and try to find an insurance product on there, and these are 18-year-old kids, Penn kids, who don't know anything about insurance because their parents take care of it. I asked them, how many people have chosen their own insurance? 3 people out of 100 raise their hand. Nobody knows anything about it, and they can go in and navigate and put in, information, and they're able to find a product that is a rational choice for them. And so these are, okay, they're Penn kids. We should all be proud of, since we're all mostly here Penn alums, that they can. So they're not, I guess the general public are not Penn undergrads, but the fact is that you can easily navigate the Massachusetts system, finding the way that it's designed is you pick kind of your flavor, whether you want bronze, silver, or gold, depending on how much you want to put out up front versus how much you want to put out if you get sick. So the bronze plan is a little bit more, you got to put out more if you get sick than up front. In the gold plan, you put up a lot in premium. So you kind of can choose which flavor, and then within the flavor you can pick what kind of toppings you want and find the plan you'd like. And it works best when the choices are constrained. So some states have said, we're only going to let a certain number of plans in the exchange, and then they can present the information in a way that's easily digestible. There's always been an exchange available, it's like ehealthinsurance.com, where you could get health insurance in the open market, but you just kind of click on something, and then there's just thousands of plans, and you have no idea what's in them, and it's impossible to make any choices between the price versus the things that are that the insurance plan is covering, and you end up making fairly random decisions. And so this architecture, this is intended to allow you to do some comparison shopping, not unlike Expedia or other types of price shopping websites you'd come across. And so a lot of states, each state is going to set up its own exchange, and many are taking an approach where they're trying to kind of guide people towards the right decisions, and others are just saying, let's let what we really need to do is just make as many choices as possible, and as long as we throw all the information out there, we've done our job, and let people decide what they'd like. I think it's my impression that later strategy isn't going to work nearly as well, both in terms of getting people into plans that work for them, but also in terms of generating a marketplace that allows insurers to compete on price. So the architecture that's set up, basically the website you see when you click on your own state's health insurance exchange, is going to make a huge difference, not only in terms of getting good matches, but allowing the marketplace to work and compete and drive premiums down over the long run.
That's great. And so another, Zeke,
so first of all, if you want to see the future before they open on October 1st, you can go to Massachusetts. That's the Mass Connector, and shop. And I assure you, you will find a plan in less than 20 minutes. I've shopped hundreds of times there. 02138, by the way, is Cambridge, and you can just use that zip code and see what you can get. It's not actually that difficult. I would say, second, at the moment, right out of the box, most exchanges are just trying to get enough insurers on there to make enough choices. They're trying to hold on by their skin of their teeth just to get open. As we progress over the next 2 or 3 years, they are going to become what Dan has pointed out, which is more active, restricting the number of insurers at each tier. There are 4 tiers in the Affordable Care Act exchanges, all the way up to Platinum. Forcing them to do things like have cheaper prices for narrow networks, creating restrictions, forcing them to pay their doctors or hospitals differently to drive prices down. I think over time you're going to see them become more active to try to reduce prices for the consumer. The third thing I would say is you don't have to rely on the exchange for the shopping experience. Initially, there won't be any added software, but soon there's going to be lots of smart kids offering software that are going to help you shop. They're going to ask you a few simple questions like, what's the most important thing to you? Price, sticking with your doctor, particular hospital, having coverage for a particular set of medicines. You're going to put in a few pieces of information, and like Amazon, which makes recommendations about what books you might want to have, they're going to begin to tell you, look at the following 3 plans. And then you'll be able to see how well they're rated on quality and what their cost is. And everything we know is what I think Dan pointed out. You have 100 choices, you kind of freeze. You have 5 choices, well, that you can manipulate. And so we're going to have a big push to get down to 5 choices where there's a sufficient amount of information. But for most people, it's going to be there are just a few variables that they care about. What is the price per month for that premium after I get my subsidy? And we know that, at least in Massachusetts, 60 or 70% of people choose on that variable and that variable alone. And that's a good thing, in my opinion, because that'll put downward price pressure. Second, your doctor. You got a doctor relationship. You want that doctor to be in that network, and so you will match price and doctor preference. If the one carrying your doctor is a lot more expensive, you'll have to make that choice. And then there's hospital, and then if you have a condition, there are special things about drugs covered, et cetera. Beyond that, how much more do people really need for a reasonable, rational choice? And so I think you're going to find, again, not in the first year, but beginning in the second and third year, a lot more apps and programs that are going to assist people in making choices. And from my standpoint, I'd be curious what Mark and Dan, you think, but from my standpoint, it's not that we want everyone to be optimized, the best plan for them that's going to minimize all their costs, et cetera. We want, all right, one of the 2 or 3 best plans where we want to be satisficers. That'll be good enough for people. And I think most people, if they had the top 2 or 3, would be happy with it. If you look at Medicare Part D, you guys probably know the data better than I do, but if you look at Medicare Part D, where they do have basically this marketplace for drug benefits, very few people have the best plan for them, but satisfaction by most Medicare patients who are in it is through the roof. And so you don't have to have the best to be satisfied here. And I think one of the 2 or 3 best is going to be good enough for most people. And so I think that's the direction we're going to go. And again, let's be a little patient. I'd like to say to my students, I don't know, Dan, if you say this, but to my students, I say, look, the American healthcare system is the 5th largest economy in the world. We spend more in healthcare in America than the entire GDP of France. All right? Got that? You're not going to change the American healthcare system overnight. and certainly not in a year. It's going to take time. So let's be a little patient. Let's not assess how good is it doing by every 3 months saying, you know, has it blown up yet? Has it blown up yet? Right? So it won't be the first year, but by the second, third year, things are going to be running much, much better because most of these are just technical problems that can be ironed out. And I do think, you know, as long as we're on the upward trajectory and not on the downward trajectory, things will be going well.
So I want to pivot a little bit to one aspect of the reform that I think has attracted a lot of attention by opponents, and that is sort of the economic impact of the reform, potential economic impact. And so I think that right now there's a lot of talk about a concern that employers are going to shift people to working, let's say, fewer than 30 hours, that employers are going to not grow above 50 employees, to not hit these thresholds where the employer mandates kick in, and some concerns about how the subsidies, given they will phase out in the exchanges as income goes up, that will potentially reduce people's incentives to work. And so there are things that cut the other way, allowing people to move more freely among jobs because they're not tied, let's say, to their jobs, to their employer's health insurance plan. But you know, I think this is one aspect of the reform that's attracted a lot of attention. So Dan, I'm curious, as we sort of look out at this reform, not January 1st or April 1st, but just over the long run, the sort of economic impacts of the reform. There are a lot of moving parts to it, and it's complicated. But what's your sense of what are going to be some of its biggest impacts?
Just to kind of catch a few people up, the way that, we talked about the exchanges, and to be able to, if you're shopping for health insurance and your income's below 400% of the poverty level, you can go into the exchange and you can get a subsidy. You can get a subsidy if your employer, does not offer you health insurance, or they offer you health insurance that's above some price, and there's a bunch of other rules that go into this and pages of regulations. But there's a certain set of circumstances where you're allowed to enter the exchange and get a subsidized health insurance product. So if you're an employer and you have a lot of low-income employees, there's a temptation to say, why don't I just, instead of paying insurance through through my human resources department, I'll just get rid of my insurance product or not adopt one and send my low-income employees into the exchange, and they can get a subsidy, and I essentially am subsidizing, getting a government subsidy for my own employees. And so if we just stop right there, you'd say, well, that, for a lot of employees that have a lot of employers that most of their employees are low income, it seems like there's a lot of incentive to not buy the products. But instead, there's what's called an employer penalty that's equal to about $3,000 if you have an insurance. Anyway, it goes on between $2,000 and $3,000 with a number of if, ands, or buts. So then you have a choice. I can pay. So now these employers that maybe weren't offering insurance before are facing a choice. So I can create an insurance product for my employees, or I can pay a penalty. It ranges between $2,000 and $3,000 for every employee I have, or everyone that enters the exchange and gets a subsidy. So the argument goes that there's these new costs to employers where it would, the rational choice on the margin would be to maybe use less employees because your employee cost has just jumped up. So as an economist, I'm supposed to say, and I genuinely actually believe this, is that while most of you get your insurance through your employer, and you see on your pay stub that the employer covers some portion of that, in fact, you're paying. You're either paying you're paying because it's part of your total compensation. And that's how hiring decisions get made, based on total compensation, not just based on what shows up in terms of the money you get to take home. And so that doesn't really change one way or the other. So you either get insurance and your total compensation includes that product, or you don't get insurance and your total compensation would be about the same and it wouldn't include that product. But that product has value. And so for a lot of employees, that product is of sufficient value to make it worth it for employers to offer insurance to their employees. And that's why we have such a robust employer-sponsored insurance program. So what I would say to the people that are really nervous about what's going to happen to our labor force, two things. One is I think we can't forget that an insurance product has value to the employee. So it's not just $3,000 or $5,000 per employee to actually buy this product and it's $5,000 down the drain, or $3,000 of paying a penalty because your employee just went on the exchange and got a subsidy. There's actually value being exchanged, so that the margin of difference is much smaller. And that's one thing. And another thing is that the total amount of money being spent here is a mere fraction of 1% of GDP. So the total macroeconomic impact of these are just as minute. And all the discussion is around these boundaries between in or out. And so there are going to be people who are going to be making these very difficult decisions one way or the other, and some employees will be affected. But it's not going to have any macroeconomic impact, in my mind, at least in terms of what's going to happen on the labor force front. I'd say the one place that there's some promise is that we're going to have a more flexible workforce. So there's this phenomenon called job lock, that people get stuck in their jobs because if they leave their job, they lose their health insurance. And they're in their job that they maybe don't like very much, but they're tied to it because of some health condition, and they really don't have any other options. So people are going to have options. And so if anything, employers might be a little more concerned about employees having a little more power in the marketplace, which could actually end up driving total compensation up, actually. And that would be also because there'd be more value created in our workforce, people ending up in jobs that are a better match for them because it's a more flexible workforce.
So I want to pick up on a point that you raised, that you sort of touched on multiple times, is the behavior of employers, how they're going to respond to this. And so coming down on the train today, reading in the newspaper about two companies that over the weekend, IBM and Time Warner, had decided to move some of their retirees' health coverage onto exchanges. And so I'm curious, Zeke, if your sense is that these moves that were highly publicized, I think on the front page of the Wall Street Journal today, for example, are those related to the Affordable Care Act, caused by the Affordable Care Act, or do you think those are things that would be happening even in the absence of this legislation? And do they sort of tell us something about what lies on the horizon, about what employers like IBM and like Time Warner are going to be doing?
First of all, we should be quite clear that for a number of years now, big companies have been getting rid of their health benefits for their retirees. This is not a new phenomena. It has been going on, I think in 06 or 08, 40% of employers had covered their retirees. It's now below 30%. It's about 28%. So it's been happening. That two blue chip companies, Time Warner and IBM, do it in the context of healthcare reform. I think gets more attention. I think there is some effect of healthcare reform on those decisions. I think it gives them cover. Of course, if you're the chief executive or the HR person, you can blame healthcare reform in some way, implicitly or explicitly. I also do think that genuinely, most big employers, the size of IBM, 400,000 full-time employees, really don't know what they're going to do over the next 5 years. They are toying with a whole series of options. They're modeling all of them from we'll just continue what we're doing to we're going to get rid of all this health insurance and give our workers vouchers or defined contributions and let them go decide. A large part of their decision will be, what's healthcare inflation? What are my premiums going up? Are the exchanges really that good, and will my workers like the exchanges? Can they actually adapt to the exchanges? And there, I think a lot will depend upon the age of the workforce that you have. The younger they are, the more used to buying everything on the internet, the more likely you are to say, hey, here's some money, go buy, as my grandmother would say, sei gesund. and I think that's likely to have a role. I think some big employers are going to, if the exchanges get a good buzz and people think they can get good options there and they're happy with them, they may, in fact, view this as an advantage. But remember what Dan said. Instead of pulling our hair out about it, what's going to happen? Well, they're going to pay a $2,000 to $3,000 penalty for each worker that goes into the exchange, each worker that doesn't take their insurance and goes into the exchange. They're going to have to jack up wages, $5,000, $10,000, because that's what their contribution to health care was before, and their workers are going to expect it. And why would they do that? Well, I'll tell you why I think they might do it. First of all, they can slim down their HR departments. They're no longer dealing with healthcare, which is a major component of HR, so you can slim it down. Second, since healthcare costs have been going up in excess of inflation, they can get their arms around inflation better and salary increases year to year better by not having to cover healthcare and putting most of that money into cash wages. And I think that's the thing they're looking at. Their conversion, if they do convert on day one, will probably be revenue neutral. $2,000 penalty, whatever they're not paying in a penalty, what they were paying in healthcare, they're going to give as a cash wage increase to everyone. It's the out years that is going to be to their advantage because they'll be raising it by CPI or growth in GDP for the wages for their workers rather than healthcare inflation. So I think that's the rationale that they're going to. Obviously, for firms with less than 50 employees, no penalty. I'm not sure why they would continue to offer health insurance rather than just give their workers a bigger boost in wages. There are theories behind this, and let's be frank. What happened in Massachusetts? All the economists predicted. Lots of dumping. Employers are going to get out of health insurance. I predicted the same thing. I'm not an economist, by the way. Turned out not to be true. Workers demanded coverage because they knew they were liable for that they had to have insurance. And so actually there was what the economists call, and almost never see, a government program that caused crowd in rather than crowd out. So usually when you offer a government program, employers stop offering that program. It's called the crowding out. The government offered it, crowds out the employer. In this case, government said you had to have insurance, crowded in. More employers offered health insurance in Massachusetts. Whether we're going to see that in other states, I think is anyone's guess. But my suspicion is if the exchanges work real well and people think their workforce is would like to do it or has experience or is young, they're going to probably experiment with it. But that's a prediction, and I'm a doctor, so my predictions are reliable. They're economists, their predictions aren't reliable. So that's another one. You can take me out to dinner if I'm right.
So we've spent the whole time talking about private health insurance coverage, the role of employers, the exchanges, and so forth. But if we look at the estimates from the Congressional Budget Office about what this reform is going to do and where it is going to have its biggest effects on coverage, it's sort of split equally between, to the extent that we're adding, let's say, 25 million or 30 million people to the insured ranks, about half of them will be in the exchange, and the other half, according to the Congressional Budget Office, will be newly eligible for Medicaid as a result of expansions in the Medicaid program. And so there's a lot of talk right now about this in many states. Michigan, their legislature recently voted in favor of expanding Medicaid. Many states are on the fence. Others are adamantly opposed. Others are embracing. And so I'm curious, Dan, what your sense is of, there's obviously, this is moving around, of whether right now we see some of the big states, a state like Texas that isn't moving forward with the Medicaid expansion, whereas an similarly large state, slightly larger California is. Is it your sense that Texas will, a year or 2 or 3 years out, embrace an expansion? Not Texas specifically, but states like Texas. There are a number of, I don't know, it's maybe hard to predict. But what's your sense? Do you think that because right now, probably 20 states are up there as saying we're not expanding Medicaid?
So I'm an economist and not a politician. So I'll tell you that the economics of it, I can't really totally understand the political decision making because it seems so not economic-y.
Are you calling the governor stupid?
But I think so. Texas, for example, and Florida is another good example. there's over 1 million uninsured in each of those states that would be able to get coverage if they followed the Medicaid expansions that are written in the law. And the way that the subsidies would work is, I guess, over a 10-year period, the federal government would contribute, I think it's like $55 or $60 billion towards insuring these 1 million eligible people. And the amount that Texas would have to kick in is about $5 billion versus $60 billion. So to insure, I mean, not to just burn the money, but to insure over 1 million people, plus the Texas has a role in paying hospitals for the care that they deliver to people who can't pay for their own health care. And that's not even if you net that 5 or 6 billion, or net of that, it's probably like more like 4 or 5. So that's the math of the decision from an economic point of view. So I'm not going to predict the politics of it because I've been wrong pretty much every step of the way. But I just think eventually everyone's going to move. Everyone's going to move. And it's a matter of 1 election cycle, 2 election cycles. But everyone's going to move. I think Medicaid, I didn't know this till after everyone started talking about it. I think Arizona didn't adopt
1982.
Medicaid till the 1980s. And the law was passed in 1965. So it took a long time for Medicaid to be in all 50 states. So if you take the long run view, which economists like to do, I think that all states will adopt, and also for the exchanges, there's a combination of flavors whether states have embraced their own exchanges, which is a much more powerful way to do them versus having it kind of done by the federal government because you don't want to get your hands dirty with it or something. And that's gonna change.
And it's interesting, though, that you mentioned Arizona because they were a state that surprised many by going forward with the Medicaid expansion. Although, let's suppose tomorrow every state changed its mind, all the states that were opposed to it, and they all decided to expand it. According to the Congressional Budget Office, under that scenario, in 3 or 4 years, about 26% of US residents would be on Medicaid. So we'd be up to almost 80 million people. And so Medicaid is health insurance for low-income individuals. Add to that the fact that Medicare is obviously, enrollment in that program is going to grow very rapidly just with the aging of the baby boom population. And we have the Medicaid and Medicare programs playing an ever larger role in the years ahead. And so I'm curious, Zeke, to hear your sense of what are the consequences for that going to be as we sort of, the exchange is important, employers are important, but these two programs are getting bigger and bigger in the sort of thinking of the players in the healthcare system. So what's your sense of what will be most important about that development?
Well, in general, I think the most important issue there is overall healthcare costs. Medicare, and if we can get overall healthcare costs to come down and healthcare inflation to come down, it'll obviously help substantially on the federal budget side of the world. And I think that's the most important issue going forward. We've been spending all this time, because the exchanges are about to open, talking about access. Now, the good news is, over the last few years, most of us think that healthcare inflation has come down on a per capita basis, and something seems to be turning in the system. I am one of those people who is wildly optimistic that we're actually going to make a very big change in healthcare inflation over the course of the rest of the decade. Why do I say that? Well, I do think that the Affordable Care Act has put in a number of structures that have focused people now on trying to get value rather than just drive up the cost by doing more things. And some of that is getting rid of hospital-acquired infections and lots of other mistakes. Hospitals that don't do that are going to be penalized by Medicare, and so they're vigorously working on this area. Second, the readmission problem. If you're a Medicare patient, you've been discharged from the hospital, your chance of returning to the hospital in the next 30 days, 20%. It's ridiculous. Should be somewhere south of 15, probably south of 12. Hospitals get dinged again, thanks to Mark and other provisions put in. Hospitals get dinged if they don't bring that readmission rate down. So I think those are focusing. In addition, there's a whole series of changes to get more integrated care, better care after hospital discharge. And I think this is transforming, when you go around and talk to various health systems, is transforming the country. Lots of places are going to do things to try to solve these problems, and they're going to make mistakes, and they're going to fail. Other places are going to succeed, and we'll learn from the successes. And I think that process has already begun and is going to accelerate over the course of the next remaining part of the decade. And so I think you're going to see a big drop in healthcare inflation.
I'll bet you dinner on that one.
All
right.
Easy, okay, but that'll be by 2020, so. So I actually do think we're going to have a very big shift there, and I think that's actually going to be positive for the federal government budget standpoint, and will be a major change. That's not to say we can't do some additional things over the next few years to sort of accelerate that process. But I think that's the most important thing to look at, is what is healthcare inflation year to year, and are we actually bringing it down? And as I've mentioned, the best way to bring it down is to change how doctors care for patients and to get them to stop doing lots more unnecessary tests and marginal things, and to begin focusing on delivering high value. And the flip side of that is most of that high value care is delivered out of the hospital. So I think you're going to see a lot of care shift out of the hospitals. As I wrote last Friday, we've seen a return of the house call. We're seeing a return of treating patients who used to be sick enough to be in the hospital at home, and those are all big money savers. So I would say you'll see hospital care decline over time from where it is now, and I think the focus on everything happening in the hospital is going to shift, and since hospitals are extremely expensive operations to run, that's going to be another, I think, big important source of savings.
Okay, so I'm going to give you each one more chance to say a bit on this stuff. So Dan, I think you are a little skeptical of the projections that the new economist we have over here.
I'm a doctor. I'm just making doctor projections.
Over here. But if we look out at the healthcare system 10 years out, many things will be changing: employers, insurers, hospitals, physicians, state governments, and so forth. What do you see as some of the potentially most important developments that you see likely on the horizon? Which players in this system do you see changing their behavior in a big way, or what have you?
Well, I think giving states more control through exchanges and the expansion of Medicaid. There's just so much experimentation going on. I mean, some states are gonna do a good job, and others not so well. And we're gonna learn from our mistakes, and things will get better that way. So I think that's just a huge development. I'm hoping that, so there's this, the Accountable Care Organization, this idea of just kind of creating incentives for the process of care, having people, hospitals work with physicians to kind of embrace the idea of the continuum of care, and creating incentive products with insurance companies to actually make it financially worth the providers' time and effort to make these innovations. I think that it's opening up a lot of opportunity for experimentation and innovation. And so when I think about some of the challenges with healthcare cost growth, it's been because there's been so much new technological innovation. That's kind of the device that goes in your body or something like that. But my hope is that it's the technological innovation in terms of organizations and systems, and the type of training that we do so well here at Wharton. We get I tell my students, it's you guys are the ones that are gonna make a difference here. And so that's where the optimism is for 10 years from now for me.
Okay. And Zeke, I'll put a similar question to you, but before I do that, I'll mention that Zeke is in the process of reaching closure on the book that is yet to be named. So
right.
Is that an apt title at this point? So, but maybe you can, without giving away too many of the the cliffhangers near the end, but maybe you can tell us a bit about where you think things are headed 5, 7, 10 years out.
Yeah. So I've just finished writing the first draft of a book on the healthcare system, and the last chapter is about 6 megatrends. So let me say first, I'm very optimistic about the healthcare system being much better at the end of the decade than it has been. But you don't have to trust me. And I'm going to cite two pieces of evidence as to why that's true. First, at I think the first Wharton Public Policy Institute or Initiative program in New York, I was where Mark was, which was moderating a panel. And on the panel was the president and CEO of Johnson & Johnson, Alex Gorski, the president and CEO of Partners Healthcare, a Wharton alum also, which is the Mass General and Brigham in Boston, a venture capitalist out in California who runs a venture firm that invests in healthcare, and Uwe Reinhardt, who's one of the leading, maybe the dean of health policy people, who's a professor at Princeton. And I asked each one of them, by 2020, would the healthcare system be better than it is today? And to a person, head of a pharmaceutical company, head of a hospital system, a venture capitalist, and health policy guy, all of them said yes. We've been in the midst of surveying CEOs and COOs of the largest hospital systems in the country, both pediatric and adult hospital systems. 70% of them think the system's going to be somewhat or significantly better by 2020. Now, almost all of them say in terms of quality. About a little more than half of them say in terms of cost control it's going to be better. And these are people who are in the trenches, who are having to manage this day to day. So here's the three virtues. One, most Americans will have a way of getting insurance, whether it's through Medicaid, the exchanges, their employer, Medicare. We're now going to have a system that's got universal coverage. Will it have hiccups and people who still fall through the cracks? Will some people, Rand Paul, still not have insurance? Yes. But we'll have a structure, which we've never had. Second, will costs be under control? You know, even if I'm not right that they're going to go to GDP plus 0, we're going to get costs down. We're going to get a substantial amount of costs through a whole variety of things, whether the accountable care organizations, the exchanges putting downward pressure, the Cadillac tax on health, premium health, high healthcare premiums putting pressure. We're going to get healthcare costs down and under control, and quality is going to be better. Hospitals are going to be a safer place to be. There are going to be fewer readmissions. There's going to be a lot more accountability for quality. So I think on all areas, if you're engaged in the healthcare system, you can be pretty optimistic about the future. That doesn't mean there aren't huge problems that will still need to be solved. You know, Mark, Dan, and I are still going to need jobs. So the system's still going to be, you know, somewhat creaky and in need of constant fine-tuning. But can we be assured, can I assure you today that the system you're going to see in 2020 is going to be better than the one you confront today? Without a doubt, I think we can be optimistic about that. And so we're Americans. We always like to be optimistic. It's a good way to end.